Hi, and welcome back to the ongoing MD, PhD, ETC lecture series. I am Dr. Robert McClay, MD, PhD, ETC, and today specifically we're going to be talking about psychosis and mental status changes, which is really a broad topic that covers delirium, dementia, psychosis. Eventually, you're going to get down into the weeds of the different types of psychosis: schizophrenia, schizoaffective disorder, psychosis associated with other conditions. But we're actually going to split this apart into three different shorter lectures this time, out of a request to make these a little bit more digestible. So first of all, today what we're going to do is talk about dealing with mental status changes in an emergency setting. So somebody comes in first time, you really don't know what's going on, they're just acting kind of strangely, and we want to know, is this something where we can let them sit and go to psych, or is this something where they need to get admitted to a more traditional hospital, or is there something we need to do emergently? So we're going to learn to ideally recognize psychosis, and eventually we're going to talk about treating psychosis and also the issues that come with treatment from psychosis. But first of all, in terms of just recognizing psychosis, what are we talking about? So, in common parlance, psychotic probably is synonymous with crazy or mad, like the Mad Hatter. Psychiatrists don't like those terms because they're pejorative, but these are people who have loss of the ability to tell what's real and not real. And the real definition of psychosis varies a little bit, but it is generally viewed to be a persistent and consistent impairment in reality testing. So the important part there is, though, persistent and consistent, because there are other conditions in which people's ability to think clearly, to judge what's real, can be altered. And on an emergency basis, when you first see someone, we need to diagnose this and split this into a couple of broad categories to try to figure out sort of three general pathways. One, that this is a true medical emergency. It's something where we need to treat what's going on, like a biochemical, physical abnormality, an overdose, a brain bleed, because otherwise our patient could die on us. We're going to look at conditions where we could just sort of shuffle them off to my usual service, to psychiatry. And those are the psychotic syndromes. And lastly, we're going to look at conditions where really we're talking about a long-term placement issue, that is dementia. There are a couple of other things that can be in the broad differential for people acting sort of strangely or bizarrely. The two others that I would add there, in addition to psychosis, dementia, and delirium, which are going to be your big differential, is also the possibility of what we call dissociation. So dissociation is basically someone's brain kind of shutting off under stress, and this can be mild. By the way, it can happen both under stress and under extreme relaxation. If you've ever been just driving home and suddenly discovered that you were there and you have no memory of it, but your brain somehow was sort of functioning but not fully, that's a dissociative state. And the more extreme examples are something like dissociative identity disorder, what used to be called multiple personality disorder. And of course, everything in psychiatry is there's the possibility of that the symptoms are falsified, either purposefully malingered, someone's doing this on purpose for a clear reason, where they're, say, trying to get a hospital bed on a cold night, or for reasons that really don't make sense, something that's what's called factitious. In other words, they have an illogical need for attention and are doing these things for that sort of subconscious drive, but they are manufactured symptoms. So that is our broad differential. So how do we start to figure this out? When in anything in psychiatry or anything in medicine, we're looking at the history is going to give us the vast majority of what we're finding for, and a little bit more on physical exam and the tiny bit that's left over from labs and brain scans and things like that. But we have to go in thinking about sort of the worst things first, and what could be really dangerous, and being able to recognize what we can very early. So ideally, if you can figure this out just by 2 minutes of talking to a patient, you're much better off than having to wait 3-4 hours for a CT to come back. So often in a psychiatrist, we're not going to really depend on those labs or physical exams at all. We're really going to depend on what the patient is telling us. And the hallmark of these sort of mental states is often a pattern that we learn to recognize that eventually becomes similar to schizophrenia. The main symptom or most recognizable symptom of that is probably hallucinations, seeing, feeling, or touching things that aren't actually there. But also beyond that, there can be delusions, beliefs in things that just simply aren't true. There can be paranoia, a distinct sort of alteration in mental state in which somebody kind of worries about everything in a borders on the delusional way. An overall altered framework of reality. In some cases, you can get something like Capgras syndrome, which is a condition in which a person believes that everything has been replaced. The real thing has been replaced by an identical copy. There can be disorganization, just basically not making sense at all. You can see someone talking in patterns that the words are just gibberish. You can see word salad, which is basically words come out, each individual word makes sense, but they're not strung together in a coherent sentence, like, therefore, nose up DB, why don't you now? Something like that. It would be word salad. And then also we look for other things that we want to rule out. And typically, if we're looking at psychosis versus, say, delirium, an altered consciousness level should not be part of psychosis. Somebody should not be going sort of in and out of this condition, nodding off, getting confused, and then coming back. So, but safety first. So, what we're looking for in terms of acute causes of mental status changes, probably the most common that I run into when something doesn't make sense, drug use is often the explanation. But also we can have medication effects, so not just illicit drugs, but prescription medications. Infection can cause these things, particularly in the elderly. There's an old maxim that a little old lady seeing butterflies has a urinary tract infection until proven otherwise. Metabolic changes. And of course, dementia can exacerbate all of this if your brain has been atrophying for a period of time. And other intracranial processes, things that are actually going on inside the brain, like a bleed into the brain, a tumor growing into the brain. Now, in terms of drugs, there are a lot of drugs out there on the streets. No list is going to be comprehensive because there's an old thing about nothing can be idiot-proof because idiots are so ingenious that despite the fact that we all know that street drugs are bad for us, new ones come along all the time. Of course, alcohol is the number one substance of abuse in America in terms of real detrimental effect, largely because of its legality. But you can get a delirious state, not just in intoxication, but actually the really dangerous one is in withdrawal. Number of other drugs can cause things that really do look like psychosis. There's some that somebody can be acting odd, but it's usually pretty easy to recognize that it's not actually a primary psychosis, it's a drug effect. For example, the effects of LSD are quite distinct. People see hallucinations, dancing lights, the walls breathing, all kinds of strange things. But they're usually quite aware of why this is going on. I'm seeing a gnome in front of me. Why are you doing that? Because I took LSD. Whereas there are other drugs that can be true, what we call psychotomimetics. In other words, they look very similar to someone who is, say, in a bipolar psychotic state. Amphetamines are very much like this, or conditions that can leave someone looking very much like schizophrenia. PCP was the classic textbook example of a drug for that. Fortunately, a lot of PCP has gone away. It's not a very popular drug of abuse anymore. Methamphetamine is the popular one in the United States, particularly here in Southern California or anywhere along border towns or places where it's manufactured, sort of in rural areas. But the effects of amphetamines are also very similar to that of cocaine. Cocaine isn't quite as potent in the moment, but can cause a similarly psychotic condition. Now, why do we care about any of these things? Because any of these drugs can kill you in overdose, possible exception of LSD. And a couple of them can kill you in withdrawal. Or really 3 of them can kill you in withdrawal. So alcohol is the big one that can kill you in withdrawal, but also benzodiazepines are barbiturates. So these are all known as sedating medications, sedating street drugs or drugs of abuse. And as they're getting out of your system, the withdrawal can be quite dangerous. In terms of prescription medications, I mentioned the benzodiazepines and barbiturates. In addition to being drugs of abuse, those are, of course, prescription medications, and if people are overusing them or they're misprescribed, they can be dangerous. But certain antibiotics can do it, things like isoniazid or rifampin. Some of the old anticholinergic antidepressants, the tricyclics, it can, if you block acetylcholine, it causes a delirious state, and some of the older psychiatric medications could actually do that. So your treatment by psychiatry could end up causing you to end up psychotic. The drugs that are used to treat Parkinson's disease, and we'll get into this a little later, but a lot of psychosis has to do with a biochemical called dopamine, of which there are 4 pathways in the brain, probably more than that, but 4 main pathways. And ideally, we're trying to treat particular conditions like Parkinson's, where dopamine is low in one of these pathways, but by doing so, we increase it in other ones and can actually induce a psychotic state. Some anticonvulsants, particularly the old barbiturates, again, can do this. Some cardiovascular drugs, so something like digitalis or methyl-dopa, again related to dopamine, can do this. Miscellaneous high-risk medications, antihistamines, actually surprisingly get the elderly in a lot of trouble. Something that's over-the-counter Benadryl you think is being pretty harmless, but because they are fairly potent anticholinergics, if you're already sort of teetering on the edge, this can end up in a psychotic-looking state. There are particular anti-cancer drugs, anti-neoplastics. Steroids are sort of infamous for this. Heavy metals can do this. So there's a broad spectrum of medications, and again, these can be quite toxic. So beyond substances, both prescribed and non-prescribed, the conditions, of course, for which those medications are there could be causing the problem. And sometimes you're at a difficult balancing situation, because is it the disease or is it the treatment that is actually causing the mental status change? But classically, metabolic disorders, a high calcium level, high hypercalcemia, high CO2 level, hypercarbia, low blood sugar, hypoglycemia, high sodium, hyponatremia, and of course just lack of oxygen, hypoxia. Overall liver failure often is associated with a psychotic state. And a lot of different hormonal change conditions, endocrine conditions, particularly, again, those that naturally secrete steroids, like something like Cushing's disease, can, just as the artificial steroid could cause this, so could the natural steroid. This overlaps, again, with a lot of neurological conditions as well. Alzheimer's disease predisposes you to this, vascular disease, diseases of the blood vessels in the brain. Parkinson's disease by itself, again, both the treatment could cause it, but the disease itself could cause a psychotic syndrome. Huntington's disease looks very, very similar. Pick's disease, Lewy body dementia, certain deficiencies of vitamins, even if it's extreme, a deficiency of niacin or thiamine or B12 and folate, those are deficient in alcohol withdrawal and thought to be one of the reasons or associations with delirium tremens. So, in other words, there are a lot of medical causes for mental status changes when someone comes in, and you don't want to just automatically assume, oh, he's just a schizophrenic, even if someone is already diagnosed with schizophrenia, because schizophrenics get sick too. They still hit their heads and bleed, and they use drugs in probably greater degree than people who don't have other mental illnesses. So we need to be careful of those things, because it's very broad. And obviously, we're not going to throw every lab in the universe at someone who comes in every time that someone's hearing voices or seeing things or acting just strangely. So how do we figure it out? Well, observation is going to be our main tool, as I mentioned earlier. And if you haven't seen the earlier lecture on the mental status exam, I do recommend reviewing that because it gives us a systematic approach for what we're going to look at, both in looking at observations of the patient, just, what do they look like? Do they have the stereotypic appearance of someone who is schizophrenic? Largely, if you've been in psychiatry for a while, you start to recognize someone who has schizophrenia or bipolar disorder across the room without ever talking to them, just because they do. Both those conditions have sort of stereotypic appearances. For schizophrenia, it's what's called the mask facies. And in other words, their face just doesn't move right. It doesn't respond emotionally the way that someone without that condition would. And with bipolar disorder, it's the opposite. These people are just bouncing off the walls. If you think about what Robin Williams looked like in a lot of his routines, where he was just talking really fast and kind of going from one topic to another, that's kind of what bipolar psychosis can look like. I don't know whether Robin Williams was actually bipolar or not, or using cocaine, which can look a lot like that as well. But we want to get a history, and again, just because you have a pre-existing condition doesn't mean that is the cause. But if you already know that somebody has a history of having bled into their brain before, or they just hit their head prior to all this happening, then obviously you want to jump to a brain scan to see if there is in fact blood there, and something we need to emergently rush to neurosurgery as well. So, what has been happening before? What led up to this? Is this a new change? Because timeline is going to be a key differentiator between our big three things that we're going to be splitting apart. That's going to be psychosis, which is the subject of most of our psychiatry talks here. But they can sit and they will respond to medications. We can treat them. It may take a few weeks. But we want to rule out delirium, because delirium is the one that can have some very, very dangerous causes. Not all causes of delirium are dangerous. Probably the most common cause of delirium, and one that I may have experienced, you may have experienced, is sleep deprivation. If you stay up for 72 hours straight, which if you were a doctor in the days of wooden ships and iron interns, we used to make people do, people can lose touch with reality. You can start blending dreams into reality quite easily with that, but it can be these very dangerous states. Versus dementia, which again is going to be a slow decline. And the main thing is the time course on this. So by definition, psychosis is a persistent and consistent change. So usually there's a point of onset. So suddenly, or at least over the course of, say, a few weeks or months, that suddenly somebody started acting quite strangely, and since that point they have stayed acting strangely. They don't go back and forth. If they go back and forth, you suspect either delirium or drug use, because maybe they used drugs, they got psychotic, they stopped, but not in terms of what we think of as a primary psychotic disorder, not in terms of schizophrenia. So with a primary psychosis, there should have been a noticeable period of onset, anywhere from hours to a few months, and since that time that they've been consistently acting in these bizarre ways. Versus dementia, what you're going to see is a slow onset over years that these things have been coming on, and that there's just been a steady decline. If you looked at this year versus last year, they're clearly worse now. If you look from the year before, you could see a difference there as well. Some dementias progress more rapidly than others, but we're still talking over the course of at least a couple of years in pretty much all of them. And versus delirium, where you're going to see a very rapidly alternating state of things, or at least over the course of days, but sometimes right in front of you. You will see somebody who's lucid and then all of a sudden is acting bizarrely, and then they're back to lucid, and particularly it can be associated with that alteration in level of consciousness. So if someone is nodding off, waking up, you worry about delirium. Now, the other thing confusing about this is that the three states can overlap and co-occur. So if somebody has already been going downhill for years because they developed Alzheimer's, they could have a new condition, again, say a urinary tract infection, that now stresses the brain and causes them to go into a delirious state. Someone could have chronic schizophrenia and been psychotic for years and now be using a medication or a street drug that causes them similarly to be delirious or could be developing dementia in their old age. For dissociation, I'll mention this one just as an aside. You're not going to worry about that as much. Dissociation doesn't require much in the way of emergent treatment. It's just sort of that it occurred only during the state of extreme stress or relaxation, but otherwise those people are going to be completely lucid. Because again, most of us has probably experienced some sort of dissociative state, and hopefully we go back to a pretty normal state. And you can snap somebody out of a dissociative state simply by snapping. Usually, that as soon as somebody wakes up, the full brain fully engages, and all these sort of strange zoning out behaviors go away. Now, falsified is a difficult thing in and of itself. Again, a whole topic of malingering and how to detect a malingering could be a subject of future lectures. But trust but verify is the bottom line, is that try to get information not just from what the patient's telling you, but ideally get collateral outside sources, talk to people's friends, family members, find out what the real history has been. Because somebody might say, oh no, I've been hearing these voices, this just happened today. You talk to the relatives, now this has been going on for years, and they just always forget that with something like dementia. So there is a mnemonic that is often used for sort of a quick screening for things that we're going to be looking for in trying to differentiate delirium, dementia, and psychosis, and that's MAD focus. And we're going to look at the aspects of memory. We're going to look at what their activities are. We're going to look at their distortions, in other words, their hallucinations. We're going to look at their feelings, there's the emotional state, because psychosis is often associated with particular alterations in mood. We're going to look at their orientation, in other words, are they able to focus? Do they know where they are? Their cognitive ability is overall, can they do math? Can they repeat numbers forwards and backwards? Can they figure out abstract ideas? If I tell them, don't cry over spilt milk, can they do this? And then there are going to be other findings, of course, as everywhere. But in terms of the overall pattern, so let's start with that MAD focus and look at, first of all, the memory deficits. So if we're looking at something that we think of as being, quote, physical or medical, it's going to need emergent care, classically these conditions cause impairments in short-term memory. In other words, if you give somebody a pattern of numbers or words to remember now and ask them to repeat it, either they'll have some difficulty even right at that repetition stage, and that's more classic of delirium. With dementia, it's delayed recall. So if you give somebody, say, 4 words, penny, table, apple, flower, ask them to repeat that back, they're like, oh, no problem. And then you do a couple of other tests over, say, a minute, and then you ask them again those 4 words. Oftentimes with dementia or other medical causes, that information just doesn't get in. So they're like, what? No, I can't remember those words. In fact, with severe dementia, they may not remember that you asked them those words. But their long-term memory, they could probably perfectly tell you what their childhood was like. These are not conditions in which somebody forgets their name or is giving sort of bizarre versions of their life history. Whereas in the more primary psychosis, it's remote impairment, that they're going to give a very strange version of their history. But if you do formal testing right now, please memorize these words, please repeat these numbers. They're not going to show a lot of abnormalities in that. So memory, to begin with, and part of our mental status exam, specifically our mini mental status exam, should be able to help us differentiate whether this is medical in an emergency or whether this is psychiatric and we can wait to give the patient an appropriate medication. In terms of beyond the memory testing, the activity level, the next thing in our MAD focus thing here is that classically people with psychotic conditions have some stereotyped movements. In other words, things like rocking or fidgeting. If they're manic, they're going to be just bouncing off the walls. Way too much energy, moving at 1,000 miles an hour, not able to sit still. Whereas a lot of the medical conditions, particularly dementias, the neurological conditions, people are going to have a lot of slowing. they're going to maybe have a tremor, some abnormal movements in the way they walk, things like that. Now, there are some exceptions that can fool you here. In schizophrenia, people can come in catatonic, in other words, basically motionless and frozen. There are some very particular characteristics of that. For example, something called waxy flexibility. So, someone who was demented might just, or had Parkinson's, might sit there for a long time. But if you move their arm, they will drop, or they will show a tremor. Whereas with someone who has a catatonic state with schizophrenia, if you move their arm, it'll stay there. It's like posing a statue. It's a really strange thing to observe. Pretty rare, but definitely can happen. Catatonia also can be somebody kind of stuck in a loop, by the way, so they have a repetitive motion that's sort of over and over and over again. Now, the thing they're often going to be complaining about, this is third in the acronym, but it's often the thing that we actually identify first, is the distortions, the hallucinations. This also ties into malingering, because people see movies, so they see a movie like A Brilliant Mind, great movie, but in real life, that individual suffered from auditory hallucinations, hearing voices and getting paranoid, because that is the classic symptom of schizophrenia. Usually schizophrenics don't see things, don't have those fully visualized. Hearing voices may not make for as good a movie. But again, the classic thing with psychosis is that the hallucinations will be things that people hear. Whereas in medical or organic causes of things, you'll often see visual hallucinations, like the seeing butterflies I mentioned earlier. Tactile is particularly suspicious for drug use or intoxication. Stimulants cause it in intoxication. This is why methamphetamines users are often called skin pickers, because they'll feel this weird stuff on their skin and they'll keep tearing at it and develop these nasty little welts or scabs there. But then from withdrawal from sedatives, so anything in withdrawal typically does exactly the opposite of what it would do in intoxication. So tactile hallucinations are worrisome. Olfactory hallucinations, so smelling something, you want to get a brain scan, because that is classically associated with seizures and with intracranial processes, something like a brain tumor. And they'll often be confused. Not sure where they are, that sort of thing. Paranoia is more classically associated with schizophrenia and with psychosis. We call it paranoid schizophrenia a lot of the times, right? Technically, that's a particular variant, but it's what we see. But that can occur with some of the other conditions. So a little bit of overlap, but more trending towards psychosis. So moving down our list from mad focus in terms of feelings. Emotions. So in schizophrenia, the overall emotions are usually sort of flat and lacking. So again, these mask-like faces where they just don't seem to respond emotionally at all, where emotional lability can also occur in psychotic conditions. So because psychosis can be associated with mania or with profound depression, but if you're seeing emotions that kind of go all over the place, someone bursting into tears and then laughing, that you suspect may be more of a medical etiology of this. Orientation, absolutely key. That again, a schizophrenic patient, someone with a primary psychosis, really shouldn't have problems with orientation. They should know who they are. They might be somewhat delusional about that. They might think, yes, I'm Tom Jones, but I'm a CIA agent. But they still know they're Tom Jones. They still know that it's Tuesday. They still know that they're in the hospital. Whereas people with things that are actually wrong with them medically can be quite confused on that point. And if you do see someone who is not oriented in that way, that is a very good reason to get a further medical workup before you would ever consider transferring them to psychiatry. Other aspects of cognition, so anyone who's dealt with anyone with dementia will tell you this, that grandma has good days and bad days. There will be islands of lucidity in that in those organic conditions, often, again, it comes and goes. There's aspects of delirium here. Whereas with psychosis, there's continuous scattered thoughts. If they're giving you word salad now, they're not suddenly going to start talking coherently with you 10 minutes from now, that they're going to still be in word salad. Now, the level of that may vary tremendously. There can be some people who are very disorganized, spouting nonsense sort of all the time, and other people who are able to hold a conversation. It's just the conversation's about aliens and the voices that are broadcasting into their heads through the energy weapons. But that's going to be there fairly consistently. So that's our MAD focus. Of course, there's always other things you should look for, always individual conditions that, after 20 years of training, or realistically 4 years of med school, you start to recognize that there's a lot of conditions that have individual things. But that is a broad thing, can really help you narrow it down. And honestly, that list by itself, that MAD focus, is in a psychiatric ER, such as where I'm sitting right now, is what I'm going to use most of the time, because I may not have access to labs and brain scans here. I have to depend on that mental status exam and looking through those things in terms of differentiating their emotional state, the type of hallucinations. And if I'm suspicious, then I will send them to a medical ER. Some other things, though, that we should be aware of, age is a big one. If you've got new onset, we used to say that schizophrenia could not start after the age of 45. We now think it can, but new onset psychosis over 40, new onsets, or I should say mental status changes over 40, deserves a medical workup. That medical workup might be just a drug screen in some case. That might explain things, but they do deserve a medical workup, because typically these psychiatric conditions do not appear after your 40s. Classically, they start in the late teens and up through about the late 20s, a little older in women than in men, but in medical conditions, there's often a sort of a hair trigger start for something. Somebody just used a drug. They just got hit on the head. They just ingested some sort of toxin, so that there is sort of a thunderbolt out of the blue onset. Whereas where I say with psychosis, it does come on rapidly, but we're still talking about over the course of days or weeks, usually, and usually got progressively worse over that period of time. Of course, if you see something physically abnormal right to begin with, somebody's got a huge mark on their head. Well, they might have fallen. Maybe we should scan their brain. They've got track marks on their arm. Might be suspicious that they were using drugs. So if you see a physical or abnormality, that you might want to look for further physical abnormalities. Always remember that vital signs are vital. That again, schizophrenia and bipolar disorder should not cause your blood pressure and pulse to go through the roof. But delirium tremens, your blood pressure and pulse are going to be going up and then down and then up and then down. So vitals are significantly off. Again, we want to do a further medical workup. Some other strange things that can happen is people who are sort of socially immodest, who just don't seem to know what's going on around them, or trying to undress in the room. That can be a sign of an organic condition. People with bipolar, again, can also sometimes get naked for fun, but classically, with more schizophrenic spectrum things, they're going to be modest, reserved. They're quite paranoid. They don't want to engage with you in a lot of cases. A sudden clear impairment in speech, almost slurring, facial drooping, stroke, right? Whereas schizophrenics, I mentioned they can spout nonsense sometimes, but most of the time, the words that come out of their mouth will be coherent words. So if it's specifically a slur that you want to think about more medical causes. I mentioned before that impaired consciousness, someone nodding off on the exam, definitely deserves more of a medical workup. And of course, again, always go back to your history. If you've got something that's there before, it does not mean that is the only thing that is there now, but we should be looking for it. If they have Parkinson's disease, we should be looking both, is their Parkinson's getting worse, and the Parkinson's medications potentially causing it. Because again, at this first stage, you don't have to tell whether this is schizophrenia versus schizoaffective versus that. You don't have to decide whether you're going to use haloperidol versus clozapine, but you do have to decide whether you're going to send someone to psych, and they're probably going to sit there for a while waiting for your neighborhood psychiatrist to show up and do the exam. versus they really need to be in a traditional ER where we can get labs, we can get brain scans, we can, treat them with poison control if they have overdosed on something. So you do want to differentiate it broadly into delirium, dementia, or psychosis. Consider the possibilities of also dissociation or manufactured conditions, but those are not going to be your main differential. This is the level at which, if you're an ER doc, you're done. You know who to consult next. But in our next lecture, we're going to talk about, presuming that we have narrowed this down, looking at the primary psychoses: schizophrenia, bipolar disorder, major depressive disorder with psychotic features, delusional disorder, factitious disorder, borderline personality disorder, and how to look at these different diagnoses. And then we'll further talk about treatments and the difficulties with treatments in our next lecture. Please continue to like, subscribe, give ideas for new lectures, and just keep learning things. Thank you so much.